We're talking about hemorrhage. This is a second section in which we'll deal with the definitions and important parameters. So, why is it important to define and characterize these definitions and parameters? That is because you need to identify the type of bleeding so that you can undergo appropriate management, you can take appropriate management steps. So, the definitions and parameters we're going to talk about will involve revealed and concealed hemorrhage. We'll talk about the primary, we'll talk about the secondary and the reactionary hemorrhage. We'll see what these terms mean, and finally we'll talk of the surgical and non-surgical hemorrhage. Again, the need for this section or these definitions and parameters is that you must be able to identify the type of bleeding because the management of each type is different. So, starting off with revealed versus concealed hemorrhage. So, as the name suggests, revealed hemorrhage might not be visible, and revealed hemorrhage might be visible, and concealed hemorrhage might not be visible. Let's see how the hemorrhage is revealed. So, revealed hemorrhage is external hemorrhage, referring to the figure. Here you can see this is a figure of a uterus. This is a fetus growing in the uterus, and this is the placenta, and here you can see there's bleeding through the cervix, and this bleeding is visible. You can see this bleeding, and this bleeding is known as the revealed bleeding or the visible or the external hemorrhage. So the examples include exsanguination from an open arterial wound. So you cut your finger, you cut an artery, and there's bleeding, there's a active bleeding from that vessel, and that is your example of a revealed bleeding. And the massive hematemesis from a duodenal ulcer, that might be visible as in the hematemetic episode, and that is also an example. Now moving on to a concealed hemorrhage. Here you can see again the same picture. It's a uterus and a fetus. This is the placenta. However, this dark colored area is the area of bleeding. So a hemorrhage has occurred in between the placenta and the layers of the uterus. However, this bleeding is being contained in that area, and you cannot see this bleeding. So the patient might feel some pressure, the patient might feel some pain in that area, but you do not know why the pressure or the pain is there. You cannot see the bleeding. So the bleeding is occurring within the body cavity. So this is a concealed type of bleeding. Now in trauma, the hemorrhage can occur in various bodily cavities. Now these bodily cavities include the chest, these bodily cavities include the abdomen, the pelvis, the retroperitoneum. So practically in any of the cavities, this concealed hemorrhage can occur. The examples of a non-traumatic concealed hemorrhage is an occult gastrointestinal bleeding or ruptured aortic aneurysm. So in gastrointestinal occult bleeding, there's bleeding that is going on that is not due to a trauma, and similarly when there's a rupture of an aortic aneurysm, it is usually atraumatic. It can be traumatic rupture as well, but usually it is atraumatic, and the concealed bleeding due to that might be an example of a non-traumatic concealed bleeding. So moving on to the next category of parameters, the next classification system, the next important definitions, we have the primary and the reactionary hemorrhages. So let's see what these are. So primary hemorrhage, they occur due to an injury or surgery. Here you can see an injury has occurred. There's a nail in the hand, and the hemorrhage that is occurring as a result of this is the primary hemorrhage. Again, there's surgery, there's trauma to the hand, the hemorrhage that is occurring, that is primary hemorrhage. So the hemorrhage that occurs due to trauma or surgery is known as primary hemorrhage. So it is occurring at that time when the trauma is being delivered. Now, reactionary hemorrhages, it is usually delayed. It is delayed with approximately it occurs within 24 hours. Now, the stimulus has been given, the surgery has been done, the damage, the trauma has been done to the body. Initially there would be no bleeding there, or there might be some bleeding, but it might be controlled, and after that, within a 24-hour period, if another bleeding episode occurs, that is termed as the reactionary bleeding. So the reactionary hemorrhage is usually caused by the clot dislodgement by resuscitation. So how that can occur? You are trying to resuscitate your patient, and during your resuscitation you are actively you're performing your CPR. As a result of your CPR, there's intense pressure, and this intense pressure causes the dislodgement of a clot that has been formed, that has been stopping the bleeding, and as a result of which the bleeding restarts. Now, it can be due to the normalization of blood pressure and vasodilation. So when the bleeding is actively occurring, what happens? The blood pressure, it falls down there because there is hypovolemia. At the same time, there is closure or vasospasm. The vasospasm tends to primarily in the arteries. There's arteriospasm, and as a result of which the blood supply decreases. So once the trauma has been addressed, the blood pressure returns to normal, and the arterio or the vasospasm that has been set in that area is released. The blood flows again through the vessels, and as a result of the normal physiological mechanisms, when they have returned and they normalize the tissue, the bleeding might restart because of the damaged area. Now, finally, it can be due to a technical failure. Example, slippage of a ligature. Now, what happened? You have pinpointed a bleeder and you have applied a suture. Now you have tied that suture. Your suture might have slipped, or your ligature might not be strong enough, and as a result of which the bleeding might occur from that area again, and this can be one of the reasons of your reactionary hemorrhage. So moving on to secondary hemorrhage. So what is secondary hemorrhage? It is due to the sloughing of the vessel wall. So what happens is there's damage to the vessel endothelium. As a result of damage to the vessel endothelium, it becomes very weak. As once this weak endothelium is further prodded, this leads to sloughing of the blood vessel and can lead to secondary hemorrhage. The time frame for the secondary hemorrhage, it occurs within 7 to 14 days after an injury. So the time frame is important. It is precipitated by factors like infection. So infection, if there's infection in the area, it can further deteriorate the condition of a damaged vessel wall. It can destroy the vessel wall further. As a result, the vessel wall might be sloughed off and secondary hemorrhage might occur. So it can be due to pressure necrosis. So why is that important? So whenever you close a wound, there should not be pressure on either of the sides. That is important because if there would be pressure, the tissues involved might get necrosed, and the necrosis can further be a cause of secondary bleeding. And finally, it can occur in malignancies, because malignancies are chronic conditions that have been there. They have been encroaching on normal vessels, and once a malignancy has been removed or even not removed, this malignancy can destroy the vascular wall, and this destruction of vascular wall can lead to secondary hemorrhage. Now, talking of the next category of hemorrhage, which is the surgical and the non-surgical hemorrhage. Let's see what these are and how to manage these. Now, surgical hemorrhage, as the name implies, it is due to direct injury. It is amenable to surgical control. That is very important. So surgical hemorrhage is always due to a direct injury. Here you can see, and you can surgically control it. It requires techniques like angioembolism. So what is angioembolization? So angioembolization is a technique in which you enter a blood vessel and you try to plug that blood vessel or embolize that blood vessel so that further blood cannot flow through it, and by doing that you try to control the bleeding. So this is a process of angioembolization, and this can be utilized in the control of a surgical hemorrhage. Now the non-surgical hemorrhages, so the blood is oozing from a raw surface. So in a non-surgical hemorrhage, there's no pinpoint area from where the blood is coming from. The blood is oozing from raw surfaces that have been damaged or crusting. It is due to coagulopathy. So there's consumptive coagulopathy. All the clotting factors have been consumed, and hence the bleeding is occurring. There's no stoppage by surgical means. So you cannot apply pressure, you cannot tie a ligature. So surgical means cannot be used to stop these hemorrhages, because it is coming from a generalized area, and from that generalized area you cannot apply pressure on the entirety of the body. Now packing is only helpful sometimes. So the packing is sometimes helpful in the sense that you try to pack the entire area that is bleeding, and once the pressure has been applied to that area, somewhat the bleeding might stop. And the packing is the only surgical means which can be utilized in a non-surgical hemorrhage. The treatment of a non-surgical hemorrhage, it requires rapid correction of the coagulation abnormalities, and to correct the coagulation abnormalities you need to first find out the cause. You need to first find out what exactly is causing the abnormality in the first place, and then once you found out that this is the cause, you need to correct the cause so that the coagulation abnormality might be corrected. So this was all about this section. I hope you liked and understood the parameters and the definitions. These are again important because this is how you manage your patient. So for further sections, keep watching sqadia.com.